Welcome to the debate. What if the very pill prescribed to relieve your chronic pain is, well, secretly rewiring your brain to make that pain worse?
Yeah, it's a pretty terrifying thought.
It really is. Today, we're looking at a diagnostic and therapeutic landscape that is, quite honestly, incredibly murky. We are examining one of the most pressing challenges in modern medicine, which is the role of opioids in managing chronic non-cancer pain. It's this fundamental tension between our absolute medical duty to relieve human suffering, right, and the profound systemic risks of opioid neuroadaptation.
Right. And, the central question we're tackling today is whether the medical community should systematically reform its approach, like actively phasing out opioids for chronic pain in favor of alternative pharmacology and behavioral therapies, or if opioids must remain a pragmatic, albeit highly regulated, option for patients who just simply do not respond to other treatments.
Exactly. And our discourse today is firmly grounded in recent clinical guidelines, pharmacological reviews, and major clinical trials. Specifically, we'll be looking at the SPACE trial, published in JAMA, alongside VA treatment protocols for cognitive behavioral therapy. I will be representing the medical pragmatist today, advocating for the careful, highly individualized continuation of opioid therapy for select legacy patients.
And I represent the reformer. I'm arguing that the underlying biology of opioids makes them fundamentally unsuitable for long-term chronic pain management.
So let's lay out our position statements to begin. I'll start by outlining the pragmatic perspective. Look, opioids are absolutely not a first-line treatment for chronic pain. The guidelines across the board are clear on that, and I completely agree.
Right.
However, they remain a necessary tool for a subset of patients with severe, intractable pain. Chronic pain isn't just a simple, electrical signal traveling up a nerve. It's an incredibly complex human experience, intertwined with a patient's psychology, their environment, their specific underlying pathologies. So for some patients, opioids provide the only reliable bridge to maintaining their quality of life and just basic daily function. I strongly caution against the rigid systemic mandates we're seeing today that force patients into rapid tapers. Abruptly discontinuing long-term therapy risks severe psychological distress, acute withdrawal, and actually exacerbates the pain itself. We simply cannot abandon our most vulnerable patients just because a drug class is, fallen out of systemic favor.
Well, I approach this from a completely different angle. Prescribing opioids for chronic pain is fundamentally a biological trap. When we look at the neurobiology, long-term opioid use forces specific adaptations in the nervous system.
The trap.
Yes, the trap. The body physically alters its receptors in a way that actively worsens the patient's pain profile over time. It's a process called central sensitization. The drugs essentially rewire the nervous system to become hypersensitive to pain.
But is that universal?
It's biological. Furthermore, empirical evidence, specifically the 12-month SPACE clinical trial, definitively proves that non-opioid medications are actually superior for pain intensity, and they result in fewer adverse effects. Therefore, the field must aggressively pivot to alternative pharmacologic and behavioral therapies. Continuing to prescribe a medication that structurally damages the pain regulation system isn't pragmatic. It's entirely counterproductive.
Okay, let's get right into the mechanics of this, because to really understand the clinical guidelines, we have to look at what is actually happening to the nervous system during long-term opioid exposure. You call it a biological trap.
I do.
Explain the mechanism there. Why does a painkiller make someone feel more pain?
It comes down to undeniable neurobiology. So when a patient takes an opioid, the medication travels through the bloodstream and binds to mu opioid receptors. Think of these receptors as docking stations, densely concentrated in the brain regions that act as your body's pain switchboard.
The thalamus, places like that?
Exactly. The thalamus, the periaqueductal gray, they are also heavily concentrated in the reward centers, which explains the euphoria. But here is where the trap springs. Long-term use triggers a vicious biochemical cycle.
Right.
The continuous activation of these docking stations sets off a cascade of intracellular signals. This ultimately leads to the upregulation of a completely different set of receptors, particularly the NMDA receptor, which is responsible for amplifying pain signals.
Wait, so the body's actively building more infrastructure to feel pain?
Exactly. But it gets worse. While it builds more infrastructure to feel pain, inflammation and nerve injury result in the physical loss of opioid receptors. You have fewer docking stations available to stop the pain. And as a final blow, when your body breaks down certain opioids like morphine, it creates a byproduct called morphine-3 glucuronide.
Oh, right.
And this byproduct actually blocks pain relief. Your body is literally creating the antidote to the painkiller you just took. To use an analogy, it's like a home security system where the alarm gets louder and the motion sensors get more sensitive every single time the wind blows. Eventually, a leaf falling triggers a 5-alarm siren.
A 5-alarm siren. Okay.
Yeah, that's what opioids do to your pain receptors. It's central sensitization. The drug that is supposed to numb the pain is rewiring the brain to feel it more acutely.
I see why you think that, and the home alarm analogy is a powerful way to visualize it. But biology on a cellular level doesn't always translate universally to the patient sitting in the exam room.
Well,
The mechanisms of tolerance you describe are absolutely real, but I'm just not convinced by that line of reasoning as a blanket disqualifier, because severe hyperalgesia, that 5-alarm siren you mentioned, it actually only occurs in a small percentage of patients.
You consider that a small percentage?
Yes, and the source material explicitly backs this up. The guidelines note that while physical dependence and tolerance happen rapidly and reliably, addiction and severe hyperalgesia occur in only a small subset of patients exposed to opioids. Addiction develops slowly, usually after months of exposure, and is recognized as a separate chronic medical illness. It is not an inevitability for everyone.
I disagree that it's just a small subset, but go on.
Let's look at the clinical reality. I've seen this in practice. You have an 80-year-old woman whose only joy in life is walking out to tend her garden, but severe osteoarthritis makes it agonizing. For her, finding a low, stable, maintained dose of an opioid achieves exactly the primary goal of pain management. It reduces the impact of pain on her mood and her function.
But
If this biological trap of inescapable, compounding hyperalgesia were a universal law, no patient would ever achieve stable long-term relief. Yet clinically, we see a whole cohort of legacy patients who maintain stable function for years on these medications.
I'm sorry, but I just don't buy that. The idea of a stable dose providing long-term relief without neuroadaptation completely contradicts the core pharmacology we just discussed.
How so?
The evidence from pain sensitization studies shows that the expression of neuronal plasticity, that rewiring of the alarm system, is a direct, unavoidable result of continuous receptor activation. It isn't a rare side effect that only happens to a few unlucky people. It's the physiological consequence of the drug doing its job.
Okay, but functionally,
You might look at your 80-year-old gardener and see what looks like stable function, but you are masking a growing underlying structural hypersensitivity. Eventually, that ceiling breaks.
well, if this trap is as absolute and universal as you claim, we should see massive failures in clinical trials. We shouldn't just be looking at theoretical biology, right? We should look at empirical outcomes. And when I look at the SPACE trial, I see a very different story.
The SPACE trial, right? Strategies for prescribing analgesics, comparative effectiveness. Yes, let's look at it, because this is the definitive trial for this exact question.
Exactly.
Published in JAMA, it tracked 240 VA patients over a full 12 months. These were exactly the kinds of patients we were talking about, people with moderate to severe chronic back, hip, or knee pain. And the results absolutely validate the reformer position.
I think the real insight from the SPACE trial is incredibly counterintuitive. You championed the non-opioid group's pain intensity scores.
Yes, because they were significantly better. On the severity scale, the non-opioid group averaged a 3.5, while the opioid group was at a 4.0. The non-opioid medications literally provided better pain relief.
Statistically, sure.
And even more critically, look at the adverse effects. The primary adverse outcome tracked medication-related symptoms. The non-opioid group had half the medication-related adverse symptoms over the course of the year. Half. This proves we should be relying entirely on the alternatives we now have available.
But what are we actually talking about when we say alternatives?
because replacing an opioid with something like pregabalin or a high-dose SNRI isn't exactly a harmless, perfectly clean swap.
They are incredibly sophisticated medications that avoid the biological trap. We have drugs like pregabalin. Instead of hitting the mu opioid receptor, pregabalin acts on the nerve itself.
Right.
It binds to calcium channels to essentially turn down the volume dial on the neurotransmitters that scream pain. You also have alpha-2 agonists like quinidine. These act like a chemical roadblock at the spinal cord. They basically tell the nerve endings to shut their doors, so the pain signal from a bad knee never even makes it up to the brain to be felt in the first place. We can target the nervous system effectively without triggering the destructive cascades and respiratory depression associated with opioids.
That's a great explanation of the mechanisms, but let's go back to the aha insight of the SPACE trial. You highlighted the BPI severity score, the pain intensity being 3.5 versus 4.0.
Right.
Well, statistically significant, a half point difference on a 10-point scale rarely translates to a night-and-day clinical difference in a patient's actual life. But here is the massive, critical detail. The primary outcome of the SPACE trial wasn't pain intensity. It was pain-related function.
You're referring to the BPI interference scale.
Exactly. How well can the patient walk, sleep, work, engage in their daily life? And on that primary outcome metric, the trial found absolutely no significant difference between the two groups over an entire year.
Well,
The insight here isn't the minor decimal points, it's the counterintuitive revelation that taking Tylenol and a nerve medication actually gives a patient the exact same physical mobility over a year as taking heavy narcotics. The scores were 3.4 versus 3.3. They're identical.
that is exactly my point. That is a compelling argument for the reformer perspective. If non-opioids provide the exact same level of physical and mental function, but with statistically significantly less pain intensity and half the adverse medication-related symptoms, that makes non-opioids the vastly superior choice.
I hear you, but
Why use a drug with profound systemic risks if an alternative gives you the exact same functional outcome?
because those non-opioids are not universally tolerated. The guidelines explicitly warn about the substantial adverse effects of the exact drugs you're praising. Pregabalin and gabapentin cause cognitive impairment, severe sedation, blurred vision, and peripheral edema, which is swelling of the legs. SNRIs, like duloxetine, carry severe risks of nausea and sedation.
Every medication has side effects. We have to weigh them against the benefits.
Yes, but context is everything in chronic pain. Think back to our elderly gardener with severe knee osteoarthritis. If you aggressively transition her from a low, stable dose of an opioid to high-dose pregabalin to achieve that exact same functional score of 3.4, you might induce severe sedation and cognitive fog.
Right.
And that fog leads to dizziness. Dizziness leads to falls. A fall with a fractured hip in an 80-year-old patient is devastating. It is often fatal. So when you say we have a clear, safe alternative, you are frequently substituting one set of severe life-altering risks for another, all to arrive at the same functional destination.
Look, I understand the risk of falls in the elderly, but the empirical data in the SPACE trial actually captured those adverse effects using a rigorous symptom checklist. And the data prove that over a year, the opioid group experienced double the adverse medication-related symptoms overall.
Over a year, yes.
Furthermore, the side effects of pregabalin or SNRIs do not include fatal respiratory depression. Mo opioid receptors in the brainstem regulate your breathing. When a patient takes too much pregabalin, they might get dizzy or sedated. When a patient takes too much morphine, their brainstem stops telling their lungs to breathe and they die.
Wow.
The mechanistic safety profiles are not remotely comparable. The overdose risk alone necessitates a systemic population-level shift away from opioids.
I certainly don't disagree that the safety profiles regarding respiratory depression are vastly different. An opioid overdose is uniquely lethal. But this brings us to the most critical and arguably the most dangerous part of this debate.
Okay,
If the medical community follows your reform push toward non-opioid alternatives,
We have to address the clinical reality of the millions of legacy patients. These are real human beings currently dependent on long-term opioid therapy. How do you actually propose we manage their transition without destroying their lives?
We manage it highly methodically. We have to systematically and objectively taper them off opioids to break the cycle of central sensitization. But we absolutely do not do it blindly. The guidelines provide very clear, evidence-based protocols for a slow, supported patient taper.
Define slow, because slow on paper often means rapid and terrifying in practice.
Allows the nervous system to gradually adapt, minimizing the withdrawal symptoms like severe anxiety, cold sweats, and racing heart rates.
And what happens to their pain while you slowly remove the primary chemical that has been masking it?
That is exactly why the taper must be supported by replacing the chemical dependency with behavioral architecture. You cannot just take the pill away. You have to address the psychosocial aspects of chronic pain. The VA has developed an incredible 6-module program called Brief Cognitive Behavioral Therapy for Chronic Pain, or CBTCP.
Okay.
It's a highly structured intervention designed to teach patients how to actively break the pain cycle.
But how does cognitive behavioral therapy break a biological pain cycle?
By retraining behavior that exacerbates the pain, it focuses on pacing activities. Chronic pain patients often fall into a trap where they overdo it on a good day, completely exhaust themselves, trigger a massive pain flare-up, and then spend 3 days bedridden.
Right. The boom-bust cycle.
Exactly. CBT teaches them to pace. It provides relaxation training to lower the physiological stress response, which we know directly amplifies pain signals. We teach them that their thoughts, emotions, and behaviors physically alter their experience of pain. It is active neurobiological retraining.
And for the patients who simply cannot tolerate the taper, the ones whose nervous systems are so adapted that a 10% drop sends them into a tailspin.
Well, for patients who struggle to tolerate the taper or who show signs of opioid use disorder, we have highly effective pharmacological bridges. We can transition them to buprenorphine. Buprenorphine is a partial mu-opioid agonist.
Explain what a partial agonist is in this context.
Think of the mu-opioid receptor like a lock on a door. A full opioid like morphine is a key that opens the door completely, flooding the system, which causes both pain relief and respiratory depression. Buprenorphine is a key that fits perfectly into the lock, blocking any other keys from getting in, which stops withdrawal, but it only turns halfway.
Okay.
This is called a ceiling effect. It provides solid analgesia, but it physically cannot trigger the severe respiratory depression that causes fatal overdoses. It has a remarkably low potential for misuse. It's an FDA-approved off-ramp that treats both the pain and the dependence simultaneously.
I am profoundly concerned about the reformer's zeal here. What you describe sounds wonderfully organized and rational: a slow 10% taper, a brilliant behavioral therapy program, a seamless transition to a safer partial agonist. But in the real world, systemic mandates for forced tapers almost always lead to patient abandonment.
But the guidelines explicitly advise against patient abandonment. They say you must maintain care.
The text of the guidelines might say that, but the cultural pivot you're advocating creates a massive stigma. It pressures clinics and physicians to get their patients to 0 MME morphine milligram equivalents at all costs.
I wouldn't say at all costs.
The FDA itself had to issue urgent warnings that rapid tapering or sudden discontinuation of opioids by frightened doctors was causing acute withdrawal, severe psychological distress, and suicidal ideation in patients. You talk about 10% a month, but institutions frequently rush this to comply with shifting quality metrics and legal fears.
But that is an implementation failure. That is a failure of health systems, not a failure of the underlying medical science. You can't say the biology is wrong just because a hospital administrator is rushing the taper.
You absolutely cannot separate the two. Medicine is practiced on humans, by humans, within systems. When leaders declare opioids a fundamental biological trap, clinicians get scared to prescribe them at all. Tapers must be entirely voluntary. They must be shared, compassionate decisions between the patient and the provider.
And here is the crucial point. If a patient's pain worsens during a taper, if their functional capacity collapses because we've removed the one pharmacological tool holding their daily life together, the clinician must be willing to pause the taper.
I agree that tapers should be paused if clinically significant withdrawal occurs. We aren't trying to torture people.
Not just withdrawal. If their pain returns and that 80-year-old woman can no longer walk to her garden, the clinician must accept that for this specific, complex individual, the benefits of continued, stable opioid therapy might actually outweigh the risks.
It's a very fine line.
It is. The guidelines themselves note that some patients are likely benefiting from opioids, and dosage reductions actively make their pain worse. We cannot sacrifice individual patients who are maintaining their lives on the altar of a population-level biological theory.
It isn't a theory, it's the observed, measured reality of opioid-induced hyperalgesia and central sensitization. But I will concede that the tapering process is incredibly delicate. The HHS Guide on Dosage Reduction emphasizes that if the existing opioid regimen does not put the patient at imminent risk for overdose, the tapering does not need to occur immediately.
Exactly.
It requires massive clinical support, time, and patience. But the immense difficulty of the transition does not justify leaving patients trapped in a cycle of worsening neuroadaptation.
Well, let's summarize where we stand as we wrap up today's discussion. From the pragmatist perspective, while opioids are undeniably flawed, carry severe risks, and should never be first-line therapies, forced systemic removal harms complex legacy patients. These are individuals who rely on them for basic function and quality of life. My position stresses that we must maintain highly individualized risk-benefit analyses rather than applying rigid biological dogma that strips a necessary tool from the clinical arsenal.
And from the reformer perspective, the biological adaptations of the mu-opioid receptor, the unavoidable cascade leading to central sensitization, combined with the definitive 12-month empirical data from the SPACE trial, prove that our historical reliance on opioids is a fundamental mistake. Non-opioids are superior for both pain intensity and overall safety. The medical community must systematically transition to alternative medications like alpha-2 agonists and pregabalin, supported robustly by behavioral interventions like brief CBT-CP.
I think where we do find substantial convergence is on the profound danger of rapid unsupported tapers. Ripping the medication away from a legacy patient without a comprehensive safety net is universally harmful. We also absolutely agree that multidisciplinary approaches, especially cognitive behavioral therapies that actively address the psychological compounding of pain and teach pacing, are vastly underutilized and underfunded in modern medicine.
Completely agreed. The psychological framework of chronic pain is just as critical as the pharmacological one. Where we remain in substantive disagreement is whether opioids can ever be a biologically sound long-term solution for chronic non-cancer pain, given how they fundamentally alter the nervous system.
Treating chronic pain is immensely difficult. It requires us to view the patient through both a strict, rigorous biological lens and a deeply compassionate clinical one. There is so much more to explore in the source material regarding these alternative pharmacological pathways, the intricate functional outcomes of the SPACE trial, and the exact frameworks used in cognitive behavioral therapy for pain.
It really highlights how much we still have to learn about human neurobiology and, the deeply subjective experience of suffering.
Indeed it does. So we return to our murky diagnostic landscape, trying to carefully tune a highly sensitive human instrument without snapping the strings. The answers aren't simple, but the conversation is essential.
The debate remains open.
Thank you for joining us.